Okay, so this is my title. I'm delighted to share with you our latest guidelines, which will be published within a week or two in the Journal of Diabetes and Endocrinology of Dubai. It's a joint effort between the Emirates Society for Diabetes and Endocrinology and the Emirates Society for Cardiology, Emirates Cardiac Society. Now, this is to suit the Emirates group of residents as well as individuals, and it's not necessarily for everyone, but I'm sure there is a lot of overlap and similarities between Morocco and United Arab Emirates. So we do need guidelines because we need to simplify and unify the process of identifying, managing, and preventing cardiometabolic complications in people with diabetes. Well, obviously, we need to address the needs of all healthcare professionals as to when to refer and how to refer and how to approach a person with cardiometabolic disease. We know from recent data that pre-diabetes and diabetes, from the data that we have published from the Dubai Household Survey, that the prevalence of diabetes is pretty high and pre-diabetes is high. Altogether, when you add them up, you end up with probably over 31% of the population have either pre-diabetes and diabetes. And we know, of course, that the figures for deciding this is diabetes or pre-diabetes are just a number, but this problem is a continuum. The relationship of lifestyle and obesity are very clear from this data that we have published. So when you look, for example, into weight, the prevalence of diabetes in people with normal weight is 8%, while the prevalence in people with obesity is 21%. Equally, exercising and not exercising, this exactly same scenario. In those who are exercising, it is 10.11. In those who are not exercising, it is 16%. So clearly, the lifestyle of the individual makes a huge difference, as you can see from the arrows now. Now, the unfortunate scenario is that 2/3 of death in people with diabetes are attributable to cardiovascular disease. So it is really important that we try to address this. And the cardiovascular disease risk factors are in abundance. Some data from Abu Dhabi on dyslipidemia shows it is up to 37% of the population. Hypertension varies according to the study from 28 to 31%. Overweight and obesity are 57 to 60%. And I've shown you sedentary lifestyle is only 17% have daily moderate physical activity. And this is moderate, not even intensive physical activity. So clearly, the reason for all of these problems is the abundance of the cardiovascular risk factors. Now, smoking is another big issue which has flourished in many countries with the move to many people smoking not just cigarettes, but shisha and even the electronic cigarettes. So tobacco smoking has now become a serious hazard. And obviously there is an underreporting of smoking in women because of cultural sensitivities. But we all obviously know that the smoking in women is a bit less. And perhaps that's one of the big factors of why men have much more cardiovascular disease compared to women. So the burden of cardiovascular disease is high with obesity as well. And of course, reducing cardiovascular risk factors in people with diabetes is crucial. And we've heard earlier the presentation about hypertension and foot problems, and a big chunk of the foot problems is vascular problems. So we now also have a paradigm shift into the management of cardiometabolic disease. Heart failure and atherosclerosis and renal failure have now benefited a lot from the presence of SGLT2 inhibitors and GLP-1 receptor agonists on top of the tightening control on all the risk factors, including hyperglycemia. So, of course, it is important to provide the primary care physician who treat over 90% of people with diabetes are treated by primary care physicians, and their time is limited. They are overwhelmed with busy clinics, and they have little time to address the consultation. So they need clear guidance on all the complexity of cardiometabolic disease. We know from STINO data that when we comprehensively, holistically approach all the risk factors, it improves outcome. The proportion of patients that died were over 21% less in those who had the intensive therapy versus the conventional therapy, with a hazard ratio of 0.55 and a p-value of 0.005. So good, important, significant factors. And we know, of course, that not only this will address the cardiovascular issues, but of course, it will also address many of the other diabetes-related complications. The Swedish Diabetes Register tell us that excess myocardial infarction due to failure to control the multiple risk factors is really a very important issue. And we need to try to address the risk factors, the multiple risk factors that some people do have. Obviously, when people have minimal risk factors, then the outcome is far much better compared to those with multiple risk factors where they have 8 times the risk of acute myocardial infarction. So, of course, we need to start screening. And screening is important in the circumstances that I've mentioned. People who have a very sedentary lifestyle. When I was working in UK, when we meet on Monday morning, we discuss, many people would discuss what they did over the weekend of physical activity and sports. But that is not the situation. I have shown you that only 17% of the UAE population would consider being moderately active on a daily basis. So hence, we need to screen, because the absence of physical activity would not stress the body to have the chest pain, the shortness of breath, and all of these aspects. People are not doing their own gardening or their own housework. Many people have many helpers or their own car wash. Many people are having helpers to do this. So, of course, we need, on top of robust clinical examination and taking history for an annual review, we need obviously to think of some of the biomarkers that are important to help us with early diagnosis of cardiometabolic disease. So, of course, we need healthy diet, we need weight loss, we need smoking cessation, we need regular exercise, we need to sleep well, which is an issue that has been overshadowed and ignored in many circumstances. And of course, we need the regular checkups, and we definitely need to manage stress, as stress is a serious contribution to cardiometabolic problems. And certainly, we need to try to tackle the sedentary lifestyle. So all of these aspects really mean good education. And I'm delighted that the Moroccan society have taken steps towards the nutrition aspects in the scientific sessions of the conference and through their activities over the year as well. So the cardiometabolic guidelines do address all the 4 important aspects: the glycemic control, the early diagnosis of cardiovascular complications, the early implementation of multifactorial intensive therapy, and also the early referral to specialists in the outpatient setting. All of this through simple algorithm that is supported by governmental regulators and hopefully the insurance providers as well to implement. So the first question we need to ask ourselves: who should we screen? And we propose in our recommendations not only to screen every person with type 2 diabetes, but also to screen every person with pre-diabetes, as many of them have multiple risk factors. And as I said, the data show that the cardiovascular problems occur in people with pre-diabetes as well. It's a continuum. As type 1 diabetes frequently occur in people who are quite young and their teens, so we suggest and we recommend that the screening for type 1 diabetes to be after 10 years duration of the onset of diabetes. Obviously, if a person were to develop type 1 diabetes at later age, then the clinical discretion of the physician needs to be applied. And then the question is how to screen. And the first step is detailed medical history, including questions of the symptoms of cardiovascular disease, symptoms of claudication, and taking a smoking status. As many people have very sedentary lifestyle, as I mentioned, sometimes it's difficult to establish a specific pattern of symptoms. But then comes the physical examination. And we recommend that every person with diabetes on an annual basis would have a full medical examination, including the blood pressure, the body mass index, the peripheral pulses, including measurement of the ABI, the ankle brachial index, and of course, a retinal examination. We also are recommending investigations, which not only would include the HbA1c, the complete blood picture, the lipid profile, and the renal parameters, but also an ECG and a proBNP. Now, the physician at their own discretion might also consider highly sensitive CRP or highly sensitive troponin. There's a slight correction here. It's not necessary to be troponin T, any type of troponin. So you see, one would argue that the vast majority of this is done by a good clinician on an annual basis. But perhaps the addition is on the ECG and the proBNP. I would expect that all the others are already recommended in the standards of care of the vast majority of diabetes societies. Now, if the person have symptoms or signs of cardiovascular disease or peripheral arterial disease or congestive heart failure, such as chest pain, peripheral edema, dizziness, palpitations, fatigue, effort intolerance, syncope, intermittent claudication, or angina, then they need to be investigated. And as we mentioned, one of the important steps with routine that diabetes clinics need to have as a routine, which is the ankle brachial index. It is not an expensive tool, and it is easy to measure in the hands of someone who is experienced in doing the test, because obviously when the test is done repeatedly, it will be much more worthwhile. How frequent should we screen? Annually. And for people who are young and perhaps with pre-diabetes and without cardiovascular risk factors, then you can ease the screening to every 2 to 3 years. So who would be considered as a screen positive? Well, anyone with an abnormal examination or physical examination, including the retinal examination and the peripheral pulse and or the ABI, as well as the physical examination. So if, of course, you hear signs of heart failure, or you see an abnormal ECG, an abnormal renal function, an abnormal retinal exam, or abnormal peripheral pulse measured by hand or by ABI, and certainly the extra addition of the proBNP, any of these factors would consider the person to be a screen positive. How to manage the person with screen positive? They need to be referred to a specialist. Now, we do not know who is the person who will be doing the screening. It could be a diabetologist, it could be a primary physician, it could be another specialist.
So in these circumstances, to refer to this relevant specialist would be important. Perhaps you would refer to a cardiologist or a nephrologist if the person had a problem, or to an ophthalmologist if you detect significant retinopathy, and certainly to a diabetologist with interest in the problem. We need to address all healthy lifestyle measures, including smoking cessation, weight management, and increasing physical activity. And of course, we need to treat all the cardiometabolic parameters as per very high risk group, and I will come to that shortly. Now, if the person is considered as screen negative, then we need to look into the number of risk factors they have. When we published our type 2 diabetes guidelines, we looked into the quantification of the risk of the individual. And here we have the risk factors segregated into the age of the individual, below 40 or above 40, duration of diabetes, 10 years or less, 10 years or more or less than 10 years, and the number of cardiovascular risk factors, whether they are 0, 1 risk factor, or multiple risk factors. And as you can see, a person who is a screen negative, so you did the examination, they have no retinopathy, their peripheral pulses are normal, their renal function is normal, their ECG is normal, their proBNP is normal, but perhaps the person is of an older age, of more than 40, with a long duration of diabetes and with multiple risk factors, then that person will be considered as very high risk and need to be screened annually. If they only have 3 risk factors, then they are high risk, 2 is moderate, 1 is low. And here you would consider screening them every 2 years in the case of pre-diabetes. So how would you manage? Now that would depend on the stage that you have. Now, as we mentioned, the people who are screen positive are very high risk, or the person who's caused 4, if they were screen negative, would also be considered as a very high risk. And here we recommend adding an SGLT2 or a GLP-1 receptor agonist with evidence, regardless of the glycemic control. If the glycemic control remains to be poor after this addition, then you would consider the addition of the other agents. The target blood pressure here would be less than 130/70, and we recommend the use of an ACE inhibitor or an angiotensin II antagonist as one of the agents in monotherapy or multiple therapy, depends on the hypertension management guidelines that you use. The LDL target here would be below 55 milligrams per DL, and we recommend to use here a high intensity statin. An antiplatelet treatment here would be indicated. In the person who is considered as high cardiovascular risk, who is a screen negative, but have 3 multiple risk factors, we do not necessarily need to start them on an SGLT2 or GLP-1 if their glycemic control is good. But if their glycemic control is not good, then that would be one of the agents that is preferred to be initiated in people with type 2 diabetes. And here we're specific with type 2 diabetes because we do not have the evidence for type 1 or for pre-diabetes in the absence of very high risk. The blood pressure target here would be below 130/70, and again, we recommend the use of an ACE or an angiotensin II. The LDL target would be less than 70, using high-intensity statin, and you might consider the pros and cons of an antiplatelet. It is not strongly recommended, but it is to consider according to the discretion and the risk of the individual. For moderate risk, then we not recommend an SGLT2 or GLP-1, regardless of the glycemic control. You would choose the agent to control glycemic levels according to the guidelines, which usually looks into the risk of the individual, the weight, the cost, the risk of hypoglycemia, as per what we all know from the standard recommendations. The target blood pressure here would be below 140/80, and the LDL would be below 100, using
a moderate intensity statin and no indication for antiplatelet. For low risk people, which would be quite a rare actually occurrence, because this means that the person only had one risk factor or none, you would use, it's more or less exactly similar to the moderate, except that the LDL here to be below 120 milligram per dl, and here you can use a moderate intensity statin. Perhaps this in our region would be a newly diagnosed young person with type 2 diabetes, someone in their early 30s without other added risk factors, where you can afford to do these measures. So it is very important to remember again that any person with cardiovascular disease or end organ damage, or those who are screened positive, should be treated as very high risk group. And of course, we need to address all healthy measures, including smoking cessation, weight management, and increased physical activity. The patient is the center of the circle. The patient might be, or the person with diabetes might be seen by a primary care physician or any of the other specialists, and the inter-referral system need to be activated according to the outcome of the screening process. Now, obviously, the problem is not in producing guidelines. The problem often is in the implementation of guidelines. We're aware that failure to make risk factors modifications is an important issue, and this can reduce odds of cardiovascular disease by 80%. Failure to elicit and follow up people's goals and needs is quite an important point, so we need to have a higher level of patient activation, which can lead to better healthcare experience. Failure to diagnose heart problems, as well as it occurs in 20 to 40%. Hypertension is undiagnosed in 20%, and hyperlipidemia is undiagnosed in 30% of cases. Failure to use proven first-line treatment is very common indeed, based on many data, and this needs obviously to be addressed. Over half of atrial fibrillation patients not on therapeutic anticoagulation. And obviously, failure to use advanced treatment, such as, for example, PCSK9, if we are failing to achieve targets in the high-risk patient, is important to try to overcome. And again, failure to provide supportive care in severe heart failure has been noted to be. And with this, I stop. I'd like to thank you, and I look forward to the question and answer session coming up later. Thank you very much.